I am very excited to conclude our discussion of digital health today with our fireside chat. Our next speakers could probably spend a whole day discussing this subject and the adoption of digital health, how it improves patient outcomes, particularly for underserved populations, and they can also swap some stories about Stanford. I would like to introduce Broderick Johnson, who will be leading our fireside chat. Broderick is the Executive Vice President of Public Policy as well as Digital Equity at Comcast. Comcast is a leader in solutions to bridge the digital divide, and Broderick works closely with their partners in government and other stakeholders to support their shared goal of connecting as many Americans as possible to the internet and shape their corporate policies that allow their businesses to grow and innovate. Broderick has more than 3 decades of experience as a lawyer, policy advisor, and political strategist, most recently with the international law firm of Covington and Burling. He has served under 2 U.S. presidents as Deputy Assistant to the President for Legislative Affairs under President Clinton, and as Assistant to the President and Secretary of the Cabinet under President Obama. Broderick also served as chief counsel for several committees in the U.S. House. He is a highly respected and trusted leader in Washington, D.C. and across the nation, and has advised hundreds of clients on a wide range of policy issues, including telecommunications and tech matters. He earned a Juris Doctorate degree from the University of Michigan. We screen for Michigan State fans, so don't worry about that. And he has a Bachelor of Arts degree from the College of Holy Cross. He sits on numerous boards, including the boards of directors of the Obama Foundation, the Black Economic Alliance, and the Congressional Black Caucus. He also chairs the My Brother's Keeper Alliance Advisory Council. Please put your hand together for Broderick Johnson.
Thank you. Ashley, thank you for the Michigan State screening that you did. Are there any Spartans here? Just want to make sure there aren't any. Are there any Wolverines here? Okay, well I am, damn it. It's great to be here, and thank you all very much. I have to say that one of the little-known effects of COVID-19 is the impact that it's had on men's collars. So I'm wearing this tie, but it is killing me. Let me tell you, I'd love to take it off, but I have to go to another event where I have to wear a necktie right after this one, so I'll keep this on. But I hope you all had a great lunch. It's nice to be here. Very much enjoyed talking about all of the things about digital adoption that are really important that we convey to people across this country as we try to really, for a historic opportunity, get tens of millions of folks signed up for the internet who otherwise would not get signed up for the internet for lots of different reasons. And so this discussion about digital health is extremely important. You know, for again, tens of millions of our fellow citizens, access to the internet is low cost, and in fact, it's free for almost 48 million Americans who are now eligible for free internet as a result of the American Connectivity Program. There are reasons that people, and we've learned this through our own programs, our own low-cost Internet Essentials program at Comcast for over a decade, that there are barriers that affect people's willingness to sign up, to trust that getting online will be helpful to them, to understanding the relevance and the impact that it can have on our lives. So this particular discussion we're going to have today is about digital health, and I'm really, really excited about the opportunity to have this fireside chat with Dr. John Halamka, Dr. John Halamka, president of the Mayo Clinic. At the clinic, Dr. Halamka leads a portfolio of platform businesses focused on transforming healthcare by leveraging artificial intelligence, connected healthcare devices, and a network of trusted partners. Trained in emergency medicine and medical informatics, Dr. Halamka has been developing and implementing healthcare information strategy and policy for more than 25 years. Prior to his appointment to the Mayo Clinic, Dr. Halamka was Chief Information Officer at Beth Israel Deaconess Medical Center, where he served governments, academia, and industry worldwide. He is a practicing emergency medicine physician, and as the International Healthcare Innovation Professor at Harvard Medical School, Dr. Halamka advised the administrations of Presidents George W. Bush and Barack Obama, as well as governments around the world, to plan their healthcare information strategies. Dr. Halamka is here with us, as you can see, remotely. He is coming to us from another big passion, big project for him, and that is the Unity Farm Sanctuary in Shelburne, Massachusetts, where he and his wife run the largest animal sanctuary in New England, which includes 300 animals, 30 acres of agricultural production, and a cidery. Is that correct? That means you make apple cider?
Correct. You got it.
Okay, great. So please join me in welcoming Dr. Halamka.
Thank you.
So it was mentioned, Stanford University was mentioned at the beginning, and we have talked about this connection. My kids got their looks and their brains from my wife, so rather than going to the University of Michigan, they decided to go to Stanford, but I won't rub that in at all. But it's great. I know you have that connection to Stanford University as well. It's quite an institution. So, but it's great. Look, I enjoyed our conversation last week as we prepared for this, and you know, this is sort of in the style of a Q&A. I have questions, and you have great answers, but I hope we have more of a discussion, more of a dialogue, more of a conversation than a Q&A session. So with that in mind, let's go ahead and proceed with the first question that will lead us into a conversation. So, Dr. Halamka, the digital health revolution began well before the COVID-19 pandemic, of course, and the mainstreaming of services like telehealth. But what first drew you to the intersection of health and technology as a practicing physician?
Well, hey, it's so wonderful to be here. And isn't it appropriate that we're doing this with a bit of a hybrid presence and virtual? I am very interested in serving healthcare globally and serving those who are underserved, and taking specialty expertise and knowledge and delivering it to places where access to specialty care can be difficult. So over these last 20 or 30 years, I've looked at, well, what are those technologies that are necessary to reach more people, to democratize access to specialty knowledge? What are the policy changes that we need? What are the cultural changes that we need? And for all the tragedy that we've had with COVID, it has been a cultural transformation that has led to the adoption of telehealth and novel care delivery methods in novel places faster than I could have ever expected.
Okay, so I'm going to call you John from now on, by the way, if you don't mind. Is that good for you?
All good.
Excellent. So our nation is facing an overall shortage in physicians, and there are millions of our fellow citizens who cannot access specialists because of geographic restrictions, for example. Now, you personally know something about this experience. The good doctor is the nation's foremost expert in poisonous mushrooms and plants, all right? And I know that's really serious. At the same time, I'm sure it's something that many people haven't recognized as an expertise. So would you talk about that expertise and how the expansion of broadband connected more people to an expert like you? First, would you talk a bit about,
Sure.
about what your expertise is in terms of poisonous mushrooms and plants?
Well, sure. So I'm an emergency physician and have been for 30 years, but I am also a toxicologist and happen to have the unique knowledge so that when I am sent a photograph, some kind of digital object from anywhere in the world, I can say, oh, I know that species. I know whether, in fact, it's going to kill you or not. In fact, maybe I can even keep your 3-year-old out of the emergency room or prevent a family member from being given activated charcoal. There are 3,500 species of mushrooms in the world. About 35 will kill you. And I have, over these many, many years, learned to recognize every one of them and then devise a treatment plan. It turns out that I am really the unique resource in this country, but yet I am accessible 24 hours a day, 7 days a week, and have been for 25 years because of this digital connection where any doctor, any poison control system, anywhere can take a digital photograph, send it to me, and get an interpretation in minutes. So how often is it that the world's top expert in any field of healthcare is available to you at a moment's notice to give you the right answer the first time, which both relieves anxiety, but also ensures you get the appropriate care, not unnecessary care? If there's any goal I have, as we chatted in our discussion last week, keeping children who ingest mushrooms and plants out of the emergency room, because that can be a very traumatic experience for all.
What was it that led you, though, to this particular expertise?
Well, so when I was a student at Stanford, so we didn't talk about this. I did a lot of hiking around the Santa Cruz Mountains and around Napa and Sonoma, and I learned what mushrooms you could eat and not. I became very good friends with a gentleman named David Aurora, who has written the definitive field guide to mushrooms. In effect, we went out hunting for mushrooms every weekend for 5 years. So I kind of have done a mushroom residency, a fellowship, if you will.
I thought you were going to say something else in terms of how people learn. I know some folks who've learned it. Anyway, I'll go on about that. I won't talk about it. But so how often, though, do you get a communication from someone with a photograph who says, I ate a mushroom and I'm not so sure that I'm going to be okay because maybe I'm seeing, double, triple vision, or there are things that are happening to me? How often does that experience come about for you? Is it regular?
So in the U.S., there are about 10,000 ingestions a year, of which I get about 900. And here's the interesting policy change, you being a policy person. Do you know that before COVID, here's the problem, I'm licensed in Massachusetts, California, and Minnesota. So given the scope of my license, I could not actually see a patient or offer direct consultation or treatment outside of those 3 states, or if there were some kinds of cross-state agreements, I mean, maybe that was an exception. But then with the rollbacks and regulatory waivers we saw during COVID, I can now offer expert medical advice, telehealth advice across the country. Mm-hmm. And that means that instead of having to rely on an intermediary, a licensed physician in a certain state calling me, I could work directly with poison control systems and with patients. So that regulatory change and allowing telehealth so that experts and patients can come together anywhere at any time was game changing.
So before telehealth, though, how would say your expertise get put in practice? How would would someone just call you or something and try to describe what it was or maybe just take a photograph? And how did that work before we really saw this growth in telehealth?
Well, the answer is not well, right? So what happens if you're an emergency physician and you have incomplete information? You want to do no harm, which means you probably treat, and then if you've treated inappropriately, at least you've treated. So if the patient, in fact, had a poisonous mushroom, they've been treated. So a lot of folks got activated charcoal or, things that are not very pleasant.
Yeah.
Before there was an opportunity to now do this near real-time consultation. Or there would be phone calls. Phone calls like, I have a mushroom. It's white. Okay. Well, that only describes about 2,000 different mushrooms. So we've been able to deal with accuracy, democratization of knowledge, real-time response, preventing harm, and getting much more satisfied patients and doctors with telehealth.
Yeah, so we'll get into that certainly with regard to just more common issues that telehealth has really changed the face of in terms of your interaction with patients. Now, the Mayo Clinic is a world-renowned center, of course, as we all know, for care and treatment of very complex medical conditions for patients really located all over the globe. How has the Mayo Clinic platform enabled your providers and patients to maintain relationships over often enormous distances while simultaneously scaling to meet demand, particularly during the pandemic?
Well, there are a couple of answers to that question. Mayo Clinic specializes in the serious and complex. Sometimes when folks think of telehealth, they say, oh, well, I am going to now talk to a provider, I'm going to get a prescription, it's an outpatient kind of encounter. Well, what about inpatient encounters? What about treating patients who are very seriously ill at a distance? In July of 2020, we launched a global command center called our Advanced Care at Home program, now able to deliver serious and complex inpatient care in the home. And that means there's a broadband connection. We're able to take patient monitors, patient devices they wear, devices in the home, understand their condition, and in our command center, offer medical interventions. And then there may be local personnel, not employees of the Mayo Clinic, but they may be community paramedics, those who've been trained, upskilled, and credentialed in a community to deliver care in the home, but under the telehealth command of Mayo Clinic. Kaiser has also adopted with us this technology. Between Kaiser and Mayo, we've seen about 10,000 serious and complex patients across the United States and international locations getting the highest quality care, but doing it over an internet connection.
That's extraordinary. I want to shift a bit to something you and I also discussed having to do with digital navigators. As I'd mentioned at the outset in my opening remarks, at Comcast, because of our 10-year experience, now more than 10-year experience with Internet Essentials, which is a product that we've offered to eligible folks, many income-constrained individuals, millions of income-constrained households and individuals over the course of time. And even at that low cost, and it's been a $9.95 per month product that we have improved, increased speeds over the course of time. And we haven't increased the price, but what we have still learned and struggled with is the fact that millions of eligible people still were not taking advantage of that offer, even with it being affordable for them. So we've worked with a number of research organizations, especially the Boston Consulting Group, to look at two things. One, barriers to broadband adoption. What are the things that hold folks back? And then second, what are some of the best approaches to getting people online, to convincing them, making them aware, first of all, of low-cost offerings, and now because of the American Affordable Connectivity Program, the tens of millions of people who can get it for free. The role that digital navigators, as we call them, has been looked at very closely by the Boston Consulting Group working with us, and they've helped to identify the kinds of characteristics of successful digital navigators programs. And typically a digital navigator program is a relatively small organization in a community of volunteers or staff who are trusted in the communities. The most effective ones are trusted people in the communities in which they work. They go, just think in terms of the challenges around getting people vaccinated, and navigators or ambassadors going into different communities there. And it's also with regard to voter registration. I mean, we've seen it over and over again in different aspects, the impact of trusted people being able to go into the communities. I want to talk to you about navigators, digital navigators in the context then of telehealth. If I were to say to you, give me sort of the prototype of a trusted person with respect to telehealth that you would send into a community of people who otherwise aren't online because either they aren't aware, or they don't trust institutions, or they don't trust government, or they don't trust the private sector And they don't understand necessarily the relevance, of course, of getting online can have to improving their lives. So in the context of telehealth, give me your sense of an effective digital navigator, organization, or person.
So I'm going to give you two exemplars. I'm going to start with one that's personal. So my mom is 80. At the beginning of COVID, of course, she was told by her primary caregiver, we are not going to have on-premise visits. My mother had not touched a keyboard in her life. And it was family members, right? And friends, trusted digitally literate folk who taught my mother how to use a keyboard to reach her primary caregiver because there was an urgency. She had to continue to get care during COVID, and the community helped her get the digital tools and the competency to directly communicate with her primary caregiver. In fact, now, if you asked her, would you like to go back to that on-prem bricks and mortar drive, wait 45 minutes in a waiting room? She said, no, I just love this notion of being able to get my care in a virtual fashion. So that's family and community. Let me talk about scale. The Bill and Melinda Gates Foundation over the last several years has been interested in delivering specialty care knowledge to northern India and sub-Saharan Africa. Here was the notion. What if you could take in a village like in Bihar state and say Patna, where a per capita income about $1 a day, and identify an individual who is trusted by that village, who would serve, as you say, as the digital navigator, so that the patients would go to the home of the person they trust. The person has a blood pressure cuff, a pulse ox, the ability to do some rudimentary testing, and transmit that over the internet to a command center, and then get a diagnosis, and then arrange a treatment. And then that person, that digital navigator, is paid for their time by being allowed to mark up medications 10% that are prescribed through the digital network. So there we go. We have a trusted person known to the community who is given a set of tools, who also has some reimbursement that ensures that they are paid for their time. And we've now put in about 60,000 of these digital navigators throughout India, and it's working extraordinarily well.
Yeah, so it can be, again, a combination of volunteers who work for Digital Navigator, community-based organizations that do Digital Navigator work, or also though people who are paid to do that work and are well-trained to do that work as a result. That combination is certainly something we see across Digital Navigator organizations that we have identified and that we're supporting. You know, of course, you're very much aware of the grave disparities with regard to income or race in this country, nationality in this country and across the world. Love to get your views on the promise of digital health as a way to address and close these disparities that you certainly are aware of and have dealt with over time.
Sure. So immense promise, but as you said, there are caveats. We all hear about the importance of AI and machine learning, the notion that digital tools will be able to diagnose disease early or detect and predict future disease. Of course, these models are based on data sets that are very often not representative of all the communities we'll want to treat. So one of the challenges is, are these algorithms that we are seeing in the marketplace, are they ethical? Are they useful? Are they unbiased? And how do you keep monitoring them to make sure they're delivering the right advice and the right care to the right patient at the right time? A number of organizations have come together in a purely nonprofit, benefit to society way. These are universities and government and industry. And we've created something called the Coalition for Health AI. You'll find it at coalitionforhealthai.org, to come up with the guidelines and the guardrails for ethical, unbiased use of machine learning in healthcare. So that's certainly a very important first step. Mm-hmm. But also understanding who trusts the technology, right, and who will find utility in it, and what are the barriers to trust we need to overcome. And sometimes that means you need a care traffic controller, as you say, a navigator, or a trusted friend who may be your agent who does this on your behalf because you lack the comfort or lack the income or the literacy. So it's a combination of making sure that the tools are accessible and ethical, and that we overcome trust issues. That is a recipe for success.
We started off talking, of course, about your expertise in mushrooms. I want to go back though to other more common sort of concerns, and particularly given that you're an emergency room physician, and how many tens of thousands of people have you seen in emergency rooms, do you think, over the course of time? It's probably, you can't even add it up, could you? Pretty extraordinary.
Well, yes, as you say, 30 years.
Yeah.
So certainly a lot of patients. And here's a challenge. Very often patients arrive in the emergency department with late stage disease. Wouldn't we want to find it early?
Yeah.
Predict it, intervene before they're very ill. And that, of course, is another key aspect of digital health.
Right.
Now, we have to be, again, a little careful here as we talk about equity. Because if we say, oh, all we have to do is ensure every patient has the latest smartphone or the latest wearable, well, that's not going to be very equitable.
Yeah, that's right.
So we have to engineer our solutions that will work at a whole variety of income and educational levels.
Yeah.
But ultimately, we want to do what is the right thing to keep those patients well and not wait until their disease requires an emergent visit.
Yeah, so I'm sure you've seen the person who comes in and thinks that he or she's having a heart attack, and in fact it's not that, but there are indications that this person has serious heart disease already, but doesn't need to keep coming back to the emergency room every time they think that they in fact are going to have heart disease. What kind of conversation would you have with that person about how they should say, get online? You won't have to come to the hospital every time you get worried about this. You get the right device, the right connection, and I can continue to give you, good advice.
Sure. So let me give you an example of a couple of things Mayo Clinic has done. Over the course of the last 2 years, we've created several machine learning detection algorithms that can look at data from such things as a wearable and determine if you're at risk for a weak heart pump, congestive heart failure, or atrial fibrillation, or problems with the heart valves or pulmonary hypertension. And these are all detectable from the devices that you have in your home or devices that you wear. Again, we have to be a little careful here as we think about equity, but point being, we have the technology now to do remote patient monitoring, continuous oversight, and not just episodic oversight when you go to the doctor's office once every 6 months, or as you say, go to an emergency department when you're in crisis. So that idea, remote patient monitoring type services with algorithms that keep you healthy, is very reassuring, but also ensures right patient, right care, right place, right time.
Yeah, and then there are the issues you and I talked about too, the adjacent issues of stress or inconvenience. Someone in the middle of their day having to go to the emergency, thinking they have to go to the emergency room, and they take time away from work, or they get to the emergency room, and because they are, perhaps suffer from white coat syndrome, for example, they come in greater anxiety than they would if they were at home, being able to, connect with you and discuss what their symptoms are, and you aware of what their record is on that, right?
Well, absolutely. And to give you a sense of adoption, before COVID, Mayo Clinic was seeing about 3% of its patients in this kind of virtual or telehealth fashion. Do you know that by April of 2020, we were seeing 95% of our patients that way? And today, we see about 25% of our patients that way.
Wow.
So there's this mindset change that, hybrid, right? Sometimes you're bricks and mortar, sometimes you're virtual.
Sure.
And that, it's just a new way of approaching healthcare and wellness, and it's here to stay.
Yeah. You also talked with me about the impact that this can all have on an entire family, right? I think you cited the example of someone in a family you were addressing healthcare concerns, and it became clear that another family member also had some issues. Would you share that example with the folks here?
Sure. So we are, all of us, deeply concerned about social determinants of health. It's not just your medical state. It's not just the capacity you have to understand your instructions and follow a care plan. It's what are the support systems around you? Where do you live? Who do you live with? Are you in a food desert? Do you live next to contaminated water or land? As we've implemented these telehealth programs, especially those where we're treating serious and complex disease, we actually do a visit to the home. We assess the home, we assess that level of internet connectivity, but we also assess the level of supports, the surrounding ecosystem of the patient. It in effect forces us to do a social determinants of health analysis. In this particular case we were discussing, we had an 87-year-old woman who had a very low sodium, needed to be hospitalized, but we treated her in the home. We found her husband, who's a cancer patient, and not acutely ill, but a chronic treated cancer patient, was having a challenge with being able to feed himself while his wife was ill. So each time we visited the home with home nursing, we brought meals for 2 people. So in effect, we brought the whole household back to wellness,
right,
as opposed to just focusing on a single person.
Yeah, that's a great example of the impact and the reach that it can have. And again, you cited one example, but I'm sure you could cite many other examples of the same thing. Mental health. We could talk about that for a second. We know that certainly throughout the pandemic that the mental health conditions, challenges, that illnesses that tens of millions of Americans face have been have really been brought to the forefront. We think about telehealth, though, in the context of mental health. Could you talk about what you see as perhaps the promise of telehealth related to addressing these mental health conditions and crisis in homes and communities across the country?
Well, absolutely. So, Broderick, I'm going to ask you a rhetorical question.
Uh-oh.
You know, how many times did you Facebook like, tweet, answer an email, or pick up your phone today? Oh, was that different than yesterday? Now, you may ask the question as a group. If you can detect depression and anxiety through what I'll call the digital exhaust from the phones that you carry, could you discover what interventions are needed and then offer a telehealth intervention acutely? Now, lest you think that's a fantasy, we've already done it. And in fact, we've done the randomized clinical trials that show, and we enrolled about 2,000 folks, that you can detect depression and anxiety from the way people use their phones with amazing accuracy.
Wow.
And then create a virtual mental health clinic designed to intervene for those who are clearly heading in the wrong direction. And this has already been done. It's already in production.
That's extraordinary. Let's talk about that later, okay? We'll have a consultation about that. I'll bring my phones out and we can see how I'm doing. Or maybe we should just wait for Saturdays when Michigan's playing and see how that goes. We're going to have a few minutes for a Q&A, but also I just want to end with this. Just your other passion while you were in Sherborne, Massachusetts, the Unity Farm Sanctuary. How'd you get involved in agriculture and animal rescue, and what do you find most rewarding about running the sanctuary?
Well, sure. So my wife was diagnosed with stage 3A breast cancer in December of 2011. It wasn't clear if that treatment would be successful because it was metastatic. She's fine today. She's absolutely fine.
Excellent.
But she said, I want to give something back to the community. I want to leave a legacy. And so we started with just a few animals, alpacas and chickens, and rescuing those that are abused, abandoned, and neglected. And then we began to expand to horses, cows, pigs, donkeys, llamas, sheep. We now have 300 large animals we're caring for at the sanctuary. And what's most, I guess, satisfying about it, we're caring for the animals and giving them lives that are very enriched. Wow. But the people of the community, now over 500 volunteers, are finding a respite from COVID, from the anxieties of the world, by caring for those animals. So in a strange way, we're treating the caregivers as much as we are treating those being given care.
Wow. Did you expect that to be the case, or have you found out along the way, the treating the caregivers?
Completely unexpected.
Wow.
And for all of us who are caregivers, you know there's a level of fatigue, compassion fatigue.
Sure.
And so what has happened is we've now become a community benefit organization where people come for peace and recovery.
That is great. That's great. Well, we're going to go to Q&A now, but first I just want to thank you for this conversation. I knew when we talked last week we would have a rich conversation, and I hope the folks here have found it to be the case. I know they have, but I certainly have enjoyed talking to you again, and maybe when I'm in Massachusetts again, I'll get to come by your sanctuary. That'd be great.
Well, that would be wonderful. And by the way, there are 143 Internet of Things connected devices on the sanctuary because every animal has telehealth.
Is that? Oh, man. Wow. Okay. All right. There you go. Well, thank you.
All right, and if you have any questions, raise your hand nice and high, and I'll bring you the microphone. Anyone? Broderick, did you have any other questions you wanted to go through? Oh,
David,
we've got one from
there.
David. All right.
So, Dr. Halamka, thank you. That was really terrific. What concerns you about telehealth and where we're going? What's going to stop us from really reaching success here? Are there any concerns, any challenges you see that we need to be focused on?
Well, and we've hit a few of them already, but one story that I told Broderick about is a few years ago. A large engineering company asked to come to Boston and visit some of our Medicaid clinics to understand how those who may be underserved are getting their care. These engineers went up to an elderly gentleman and said, "What is your favorite wearable?" And he said, "Socks." We have to meet our patients at the level of their comfort, the level of their trust and understanding. So I think it's just very important to realize that there's not going to be just one size fits all telehealth solutions. We've talked about the notion that you may need care navigators, digital assistants, and those go to the patient and bring the services and build the trust and the literacy. And sure, there are going to be those that are going to have next generation devices and want different kinds of algorithms and other things, but it's a whole spectrum of solutions. We better engineer for that entire spectrum as we deploy this more broadly.
Excellent.
All right. Anyone else have a question?
Thank you, Dr. Halamka. You touched on mental health and telemedicine. And as you know, we have a crisis in this country with our veterans and the suicide rate and access to mental health services. And in fact, we have an upcoming panelist whose organization started a program within the Air Force to help deal with the overflow and the demand using telehealth to help take the patient information so the caregivers could focus less on admin and more on providing care. What are we not getting done, or what are the barriers to fully realizing telehealth for our veteran population? What more can we be doing in Washington?
Well, and you can guess this is a very unusual time in healthcare with what I'll call the Great Resignation and the Great Realignment, the notion of folks retiring early and burnout. So as you've hit, I think, a couple of points there, we have to reduce the friction to delivering care, and that we have to continue to train and develop those of all kinds of skill sets who are going to be able to deliver the care. As I mentioned, Mayo Clinic, for its advanced care at home, is not deploying, say, a doctor into the home. We have doctors in remote command centers, and then we are upskilling paramedics in each community to be these more advanced care deliverers in the home setting. So I think as you look at education and training and enablement of all the various different levels of skill set, as well as reduction of barriers and friction, that is the only way we're going to deal with this overwhelming demand for services that we're seeing now.
All right, that was our last question. So please thank Broderick and John for joining us today. This was a fascinating conversation.